Assalamualaikum warahmatullahi wabarakatuh. Dear students, belated Eid Mubarak. I hope you all enjoyed Eid at your homes. Bismillahirrahmanirrahim. So today we will discuss subfertility, its causes and investigations. Infertility is not a new problem. It's a gynecological issue since very long throughout the history. However, its rate is now increasing due to certain reasons. You must have heard of a test tube baby, uh, whose name was Louise Brown. She was a girl born by test tube in 1978 in Oldham General Hospital, UK. And Robert G. Edwards, the physiologist who developed the treatment, was awarded the Nobel Prize in Medicine in 2010. So what do you understand by test tube baby? Do you have any idea what does it mean? Test tube baby doesn't mean that the baby is born in the test tube. It means that the fertilization is done outside the human body. We pick up the ovum and take the best uh, sperm, and they are fertilized in a petri dish outside the human body. And after fertilization, that conceptus is implanted inside the uterine cavity or inside the fallopian tube at various stages of the development. So that technique is called artificial reproductive technique. So this is what is test tube baby. Fertilization is done outside, and then this zygote is implanted inside the, and this zygote is implanted inside the human body, inside the uterine cavity or in the fallopian tubes, where it grows later and then delivery takes place. So this is how the test tube baby was born. So today's lecture's objective is that you should be able to define infertility, identify the risk factors, and list the causes of infertility, justify the investigations, and manage the infertility. That will be in the next lecture. So, how you will define subfertility? It can be defined as failure to conceive after regular coitus for 1 year. If a couple fails to conceive after a regular coitus for 1 year, then it is defined as subfertility. On average, infertility affects 1 in 7 couples. For every 7 couples, there is one infertile couple. So it can be primary or second infertility. Primary fertility when a couple never conceived, and secondary, they have conceived, but later on they have failure to conceive. So a careful history, examination, investigation, and when necessary counseling should include both partners. So infertility clinic is a place in OPD where both husband and wife, they are called, and they are uh, taken history, examined, and investigations are advised. So this is the only problem in gynecology in which we call the husband also. So you should understand the prerequisites for conception. What are the prerequisites? What are the conditions that must be fulfilled before conception? First of all, regular ovulation with production good quality ovum. So there should be ovulation. Eggs should be produced of good quality. Patent fallopian tubes. The fallopian tubes they should be open, patent for the passage of sperm. Receptive cervical mucus for sperm. So the cervical mucus it should be receptive so the sperm can uh, go through the cervix into the uterine cavity and into the fallopian where the fertilization takes place. Good quality semen. So semen should be of good quality. Husband should be a fertile, potent man. So he should be potent. If the husband is impotent, then all the prerequisites they are of no use. Normal uterine cavity suitable for implantation. So, uterine cavity it must be normal. It should not be distorted. It should not have any adhesions or any growths inside or tumors. So, it should be a normal uterine cavity so that implantation can take place. As you can see, there is ovum. Ovulation takes place over here, and this ovum is released and picked up by the this fallopian tubes, and it traverses the fallopian tube. While the sperm it enters the vagina and through the cervix into the uterine cavity and passes into the fallopian tube where the fertilization takes place. And after fertilization, this zygote it is traverses the fallopian tube and enters the uterine cavity and gets implanted inside the uterine cavity. So, what are the prerequisites? Ovulation of good quality ova, patent fallopian tubes, receptive endometrium, and receptive cervical mucus, uh, allow the ascent of the sperm, good quality semen, and a potent fertile male. So these are the prerequisites for conception to take place. Infertility, it have number of factors which can predispose a couple to not to conceive. First of all, age. Age is very important. After 35 years of age, female fertility declines due to poor insect quality and vital frequency. Stress and anxiety may affect the libido. So, if a couple they have vital frequency once in a month or once after 2 months, this is not great. So, it will not lead to conception. And if a couple they are passing through a stage of stress and anxiety, it also affects the libido and ovulation. Then alcohol usage. It may affect the sperm quality and the fetus also. It has effects on quality and the fetus. BMI. If it is less than 19 and if it is more than 29, it affects the ovulation also. So very low BMI and high BMI, it will affect the quality of the ovulation. There are certain drugs which affect ovulation, non-steroidal anti-inflammatory drugs. Then chemotherapy, it destroys the gametes. Then cimetidine, subfertility, androgens affect system quality. They have affected the male fertility. Occupational hazards include chemicals and radiations. It decreases the fertility. And also the welders, they have also uh, oligospermia or is azoospermia due to increased temperature. They are exposed to excessive temperature, which will suppress the spermatogenesis. So these are the occupational hazards. Painters also, and radiographers, they also have low quality symbol. This pie chart shows the prime causes of infertility. Majority of the cases, about 28%, they are unexplained. You cannot find any cause. Everything seems to be normal. And 21% they have male factors, sperm problems. 18% they have ovulatory failure, and approximately 14% they have tubal factor. 9% they have endometriosis or cervical mucus factor. 5% coital problems, and 5% include other problems. So this pie chart gives us a brief overview of the causes of infertility. The majority of the cases, they are unexplained. Now, female factors which lead to failure to conceive, they are ovulatory disorders, tubal blockage, endometrial factors, and cervical factors. So, you can recall, the prerequisites for conception, they are good quality ovulation, pattern tubes, receptive endometrium, and good quality cervical mucus, which allows ascent of the sperm. So, if any problem in these four areas, it will lead to failure to conception. So, ovulatory disorders, tubal blockage, endometrial factors, and cervical factors. Ovulatory disorders include if there is any disruption in the hypothalamic pituitary ovarian axis, it will lead to gonadotrophin deficiency, hypergonadotrophic hypogonadism, or it may lead to polycystic ovarian disease, or there is premature ovarian failure. Premature ovarian failure, it may be congenital or it may be acquired. Congenital include Turner syndrome and acquired. There are other causes like iatrogenic menopause with surgery, radiotherapy, chemotherapy, or if the patient has resistant ovary syndrome or premature ovarian failure. Hyperprolactinemia is another cause which suppresses the ovulation. There are certain drugs, pituitary tumors, primary hypothyroidism, they all cause hyperprolactinemia. So if whenever there is hyperprolactinemia, it will suppress the ovulation. Weight changes if there is very low BMI or high BMI, less than 19 or more than 29, it will also affect the ovulation. There are certain drugs, tricyclic antidepressants, methyl digoxin, they will also suppress the ovulation. Thyroid disorders are also responsible for failure to conceive. If she has hypothyroidism, she may have infertility also. The second factor is tubal blockage. It may be the result of any infection, pelvic inflammatory disease due to chlamydia infection, any inflammatory process in the abdomen or pelvis, which may block the tubes. Uh, if she had any pelvic or uterine surgery, the patient may have post-surgical infection, which may block the tubes later on. Endometriosis is a leading cause to adhesions and tubal blockage. In endometriosis, what happens? It will cause adhesions, peritubal adhesions, and it will distort the tubes, affect its motility, peristalsis, and obviously it will lead to tubal blockage and subsequently infertility. Now, endometrial factors include any kind of tumor like fibroids or endometrial polyp, cervical polyp, interuterine adhesions may interfere with implantation. How these interuterine adhesions occur? Uh, Sometimes when the patient has therapeutic or diagnostic curettage. There is overzealous curettage of the uterine cavity. What does the obstetrician or gynecologist? The gynecologist curate the endometrium up to the basal layer. So they curate the basal layer also. So what will happen? There will be Asherman syndrome. It will lead to intrauterine adhesions and failure to menstruate. She will have secondary amenorrhea and subsequently she will have infertility. So these were the endometrial factors. Now cervical factors. Reduced cervical mucus if the mucus is not adequate or they are antibodies. In this mucus, then what will happen? They will attack the sperm and it will lead to destruction of the sperm and subsequently failure to conceive. This is hypothalamic pituitary This is ovary and hypothalamus. So from hypothalamus, gonadotropin releasing hormones that are released, which act on the pituitary to release FSH and LH, and FSH and LH will act on the ovaries. These are the ovaries, and it will cause follicle stimulation, and LH surge will occur, and ovulation will take place, and then correction, which will secrete the progesterone. And under the effect of FSH, the estrogen is released. This is the mechanism of ovulation. So after ovulation, progesterone is secreted. So serum progesterone level is a marker of ovulation. As you can see over here, different causes of infertility. This is due to endometriosis, there are peritubular adhesions, and it leads to tubal blockage. This is uterine abnormality. As you can see, there is no continuity of the uterine fundus over here. There is a uterine sac, and there are fibroids which distort the uterine cavity. There may be an endometrial polyp which will also distort the endometrial cavity. Then these ovaries, they show small polycystic ovaries. So this is PCO, polycystic ovary, in which there is no ovulation. As you can see over here, due to some infection, there is tubal blockage over here. This is patent tube and up till here, and now there is a blockage, which will also hinder the passage of sperm and ovum. And if there is any allogeneic tract infection, it will also lead to cervical fracture to prevent um, the ascent of the sperm. Again, these are multiple fibroids which are distorting the uterine cavity. Again, here multiple fibroids. This is fibroid, intramural fibroid. This is subserosal fibroid, and this is the submucous fibroid. So it is distorting the uterine cavity. And this is the fibroid polyp, cervical fibroid polyp. So it is blocking the cervix also and distorting the cavity also. So these are the different causes of which may lead to infertility or subfertility. This is another pie chart which shows different causes of infertility. Now, male factors which are responsible. In males, first investigation is semen analysis. So we see in semen analysis the sperm count, their mortality, their morphology, any infection, any RBCs, and motility in forward direction is also noted. So low sperm count means less than 20 million gonadotropin insufficiency, impaired testicular function, induction system defects in semen selection. These are all factors which may lead to low sperm count. Reduced motility is when there is less than 50% motile sponge. Motility, it should be in forward direction, not in backward direction. So temperature may affect, as I told you, that welders, they have increased temperature, they are exposed to increased temperature, they have they have effect on the systems. Infections, epidermolysis is infection which may reduce fertility. And anti-sperm antibodies, if there is anti-sperm antibodies in the cervix, it will destroy the sperms. Then this is abnormal. It may occur in pregnancy, in infection, in drugs like nitrofurantoin, which will affect morphology. Now volume. If it is less than 1 ml, then it is reduced volume. It may be due to improper collection of the specimen, retrograde ejaculation, or absence of shorter duration. So, whenever you ask for semen analysis, we always advise the people to abstain from blood test for about 3 days at least, not less and not more. So, if the absence of shorter duration, it will also affect the volume. Coital problems, impotence, if the husband is impotent or they have low coital frequency. This is see over here. This is the glans penis, and this is the vas deferens. This is scrotum, and this is epididymis. These are that it is um, this vas deferens to the this is hypothalamus. If there are problems in the pituitary hormones FS and LH, then it will also lead to the infertility uh, due to altered sperm production. If there are problems in the vas deferens, blockage of the transport, if there's blockage in the vas deferens or in the ejaculatory duct, it will also lead to sorry for the disconnection. As you can see in this picture, if there is problem in the hormones that due to TFSH and LH, it will also lead to effective sperm production. If there is blockage in the transport system, it will also affect the semen analysis or sperm production in the testes or erection and ejaculation problems. So these are the 4 problems in the male. A hormonal problem, blockage of the duct, sperm production problems in the testes, and ejaculation and erection problems. So we all know that for conception we need a single egg and a single sperm. So a single sperm of good quality is required for fertilization of a healthy egg, which will ultimately lead to a conception. So whenever we uh, call a couple in the infertility clinic, we start from the history examination, and then we advise some investigations. And in the light of all these examination and investigations, we will try to find out the cause of infertility. So while taking history, we have to take the history of both male and female partners and examine them both separately. In female, we ask about the duration of infertility, whether it is primary infertility or secondary infertility, coital frequency, how many times the couple practice coitus per week, and occupation of both husband and wife, menstrual history, whether the menses they are regular or they are irregular, history of any pelvic inflammatory disease or any other infection, previous medical and surgical history, if she had any previous medical illness or she had any previous surgery. Also, we will take the history if she had taken any fertility treatment before, cervical smear history, whether her cervical smear pap smear has been taken or not, and also we will screen for the thyroid disorders. We will ask for the sign and symptoms of thyroid disease. In case of male, we will ask about the duration of infertility, whether he had fathered any previous pregnancy, history of mumps or measles, because if there are mumps or measles, they cause epididyma orchitis and it will lead to infertility or gynecospermia. History of testicular trauma or surgery. Any testicular trauma or surgery like vasectomy, ligation of the vas deferens as a permanent sterilization procedure. It will also lead to infertility. Occupation, like if the husband is a painter, welder, or he's a radiographer, these all these occupations there is the spermatogenesis, and we will also take the medical and surgical history. Now we will start examining the couple. First female and then male. In female, we will do gynecological examination, then pelvic examination. Pelvic examination include both, general physics examination, then abdominal examination, and pelvic examination. In pelvic examination, we will do spur speculum examination and biomagnum examination. While in case of male, we have to examine the testes, the scrotum is examined for the volume, consistency, any masses, absence of vas deferens, and any varicocele and any surgical scar marks. So this is how we examine the male and female partner. As you can see over here, this is the testes and this is varicocele. These are the dilated veins of the spermatogonia. This is varicocele. You can see over here, this is varicocele. It is a tortuous mass on the surface of the scrotum. What investigations we will advise? Investigations they are advise both male and the female partner. In case of female partner, the first prerequisite is ovulation. So we have to determine whether the patient is ovulating or not. So it can be detected by day 21 serum progesterone. As I told you that after LH surge there is ovulation. And after ovulation, the follicle is converted into corpus luteum and it will start secreting the progesterone. The progesterone will be secreted in the second half of the menstrual cycle. So we will do day 21 serum progesterone. If it is high, it means that ovulation has taken place. Then in case of follicular phase, on day 2 we will do FSH, LH and estradiol level, and also testosterone level and TSH. So these are the hormone profile which is asked to be done in the follicular phase on day 2. Then ovarian ultrasound, it may be transvaginal or transabdominal to see whether there is a uh, mature graphic follicle is formed or not. And basal body temperature charting. This is another observation that after ovulation, the basal body temperature rises about 0.5 to 1 degree centigrade. So the female continuously monitoring her temperature, and whenever there is after mid cycle, there is a rise in the temperature about 0.5 to 1 degree centigrade. It means that she has ovulated. So this is basal body temperature chart. Tubal patency, hysterosalpingogram. This is tubal patency is checked by three ways. Either HST, hysterosalpingogram, hysterocontrast sonography, or 3D using 3D ultrasound and operative laparoscopy with dye testing. So hysterosalpingogram is an X-ray of the tubes. What we do, we inject dye from the cervix, radio opaque dye. It is injected through the cervix via cannula, and then we take two X-ray films at 5 minutes apart. The dye will outline the uterine cavity to go through the tubes and it will be spelled inside the peritoneal cavity. So, if there is a spill in the peritoneal cavity, it means the tubes are patent. And if there is no spill and the dye does not reach the tubes, or they reach the tube but it is blocked somewhere, then it means the tubes they are blocked. Then there is another way, hysterocontrast sonography, using 3D ultrasound, in which we inject a saline into the uterine cavity, and then we do ultrasound and see the saline particles that are going through the uterine cavity into the tubes. So it will outline the tubes also. Then there is operative laparoscopy and dye testing. What we do laparoscopy using pelvic cavity, uterus, tubes, and ovaries. And at the same time, we are passing the within blue dye from the cervix via cannula into the uterine cavity. And this dye is forced to go upwards from the uterine cavity into the fallopian tubes and into it spills into the peritoneal cavity. So you have a camera inside the abdomen and you have passed the dye from the cervix, and you can visualize if the dye passes through the tubes in and spills over the into the peritoneal cavity, then it means the tubes they are patent. And if there is no spill of the dye into the peritoneal cavity, it means both tubes they are blocked. Sometimes one tube is blocked and the other is patent. So you can directly visualize the patency of the tube by dye testing. Then uterine factors, they can be evaluated with the help of the stereoscope. This is a camera which is inserted inside the uterine cavity, and we can directly visualize this uterine cavity, whether there are any polyps or there are any submucous fibroids or there are any adhesions. They can be directly visualized through this hysteroscope. So these are the ultrasound picture of the ovary. This is ovary, and this is the mature graphene follicle. This is a mature graphene follicle. So it will uh, rupture and release the ovum into the vaginal cavity, which is picked up by the fallopian tubes. So as you can see over here, this follicle, after ovulation, it is now collapsed, and there is free fluid. This is uterine cavity. This uterus. This is pouch of Douglas, and here there is free fluid. It means that the follicle has ruptured, releasing the fluid, antral fluid, and releasing the ovum, and the remaining graphical follicle it becomes corpus luteum and starts creating progesterone. This is a picture extra of a hysterosalpingogram. It shows the hysterosalpingography of the uterus. Dye is injected from the cervix. It is pushed upwards into the uterine cavity. As you can see, the uterine cavity is outlined and it passes through the fallopian tubes and then it spills into the vaginal cavity. So this is how you see that both the tubes they are patent and there is spill of dye into the vaginal cavity. So this shows that the tubes they are patent. This is uterus. This is another hysterosalpingogram which shows the uterine cavity is outlined. The dye is close to the tube, but the tube is dilated. So this is hydrosalpinx, grossly dilated. So this is how we see grossly dilated hydrosalpinx. And here also the dye passes through this fallopian tube, and the end is fibril and is blocked. And so they have this patient she has bilateral hydrosalpinx due to some infection. This is the transvaginal ultrasound. This is the probe of transvaginal ultrasound. This is TVS transducer. We insert this probe inside of the vagina into the stereofornix or enterofornix to visualize the ovaries and the uterus. This is picture showing hysteroscopy. We introduce the camera inside the uterine cavity and we can see this is the uterine cavity and this is the endometrium and this is the tubal ostium. This is the tubal ostium. So this is how we visualize uterus inside the uterine cavity via hysteroscopy. This is laparoscopy being done. This is the laparoscope inserted into the vaginal cavity, and these are the cannulas. This operative laparoscopy. This is uterus. If we inject the dye from here, so with the help of this laparoscope, we can visualize the free spill of dye to the vaginal cavity on both sides. This is a laparoscopic view of the vaginal cavity showing PID, pelvic inflammatory disease, and adhesions and endometriosis. So these are the adhesions. Ovaries and uterus with other pelvic organs. This is uterus, this is ovary, which is buried behind the uterus, and this is ovary with endometrium. So this is again polycystic ovaries. These are all laparoscopic views. This is uterus. This is they have polycystic ovary. So they have polycystic small cyst, 0.8 centimeter. The cervical factors. Cervical factors directional sperms are seen per high-power feed. Negative test indicates poor quality semen and coital difficulty, cervical mucus deficiency, or presence of mucus commonalities in either partner. So, post-coital test, how it is done, we advise the couple to practice coitus, and after that, after coitus, the specimen is taken from the posterior fornix of the vagina, and this specimen of the semen is then examined under microscope. If you find 5 to 10 motile unidirectional sperms, then it means it is normal. And negative test may indicate that the semen is not good, there's got a problem, or cervical mucus deficiency or presence of antispermatic. So this is the latest investigation. Female reproductive tension is directly proportional to the remaining number of the oocytes in the ovaries. So this is called ovarian reserve. The number of oocytes in the ovaries is the ovarian reserve. It declines after the age of 35. As soon as the female gets 35 years old, the ovarian reserve starts decreasing, and it predicts the response to ovarian stimulation and ART. So if she has a good ovarian reserve, then she will have a good response with IVF techniques. Andral follicle count, it is seen on the transvaginal scan. It is a good indicator of ovarian reserve. So both andral follicle count and antimonal hormone, they are a predictor of ovarian reserve. So if it is less than 4, this andral follicle count, then it has low response with ART, artificial reproductive techniques. And if it is more than 16, then the response will be good. Antimullerian hormone, this is a hormone which is produced by the granules of cells. Measured by antral follicular count, which is done by TBS, and antimullerian hormone investigations. Now, investigations in the male body. Semen analysis, it is performed after the abstinence of coitus for 3 to 4 days. 2 abnormal tests are required to diagnose male infertility. And normal parameters of semen analysis, according to WHO criteria, they are given. The volume, it should be 1.5 ml. pH, it should be more than 7.2. Sperm concentration, it should be 15 million per ml. Total sperm numbers, at least they should be 39 million per ejaculate. Positive progressive mortality, it should be around 30%. Regarding morphology, normal forms, they should be at least 4%. And vitality, life sperms, they should be about 58%. So this is the WHO criteria, that is 5th centile. These are the sperms. This is a normal sperm, head, body, and this is tail. So this is a normal morphology. Sometimes head is too big, sometimes it is too small, sometimes it has two heads, sometimes two body pieces, and sometimes the head is like this conical. Sometimes the tail is short, sometimes the body piece is long. So all these started from here to here, they're all abnormal sperms. So this is a normal sperm. So this sperm is required for conception, for fertilization. So when you see under a microscope, this is the normal sperm count. Normal sperms they are seen, and this is the low sperm count. Hormonal assays. As I already told you that if there is problem with the FSH analyte and testosterone level, so we have to do investigations. Testosterone level, if it is low, it suggests production impairment. And FSH level, if they are low, then it shows hypogonadotrophic hypogonadism. There should be screening for the cystic fibrosis mutation, as congenital bilateral absence of vast difference is a minor variant of cystic fibrosis. Now, karyotyping. It is indicated if there is azoospermia or severe oligospermia, testicular atrophy, and raised FSH levels. So these are the indications for karyotyping. Semen fructose is also observed in semen analysis. Absence or reduction of the fructose in semen suggests HMS is a positive. And testicular biopsy is done to confirm outflow obstruction. Sometimes there is azoospermia or oligospermia, and to rule out obstruction in the vase, we have to do testicular biopsy whether it is obstruction. Due to obstruction, there is azoospermia or melismia, or this is due to no production of sperm. So these are the investigations which are done in both partners. In vitro mucus penetration test, sperm penetration test, and sperm cervical mucus contact test for antibodies. So, in short, the take home message is infertility is a significant medical and social problem affecting couples worldwide. So, it affects their marital life. It is a sensitive issue that should be handled with great care, with continuous professional counseling. Counseling matters a lot in infertility. You must counsel. If there is no cause, it may be unexplained. So they can conceive at any time. Counseling is very important in case of infertility. Most young couples will conceive naturally within 2 years. So you should counsel them that you can conceive, you can wait. Evaluation of both partners for causes is essential. I have already discussed with you that we have to take both history, examination, and investigations in both husband and wife. Treatment depends on the cause, and it varies from medical treatment to surgery to artificial reproductive techniques. So the treatment it depends upon the cause, whether it is a female factor or male factor. Okay. So these causes, according to the causes, we have to treat the patient. So this is all about subfertility. Thank you very much for listening to me and to be with me. If you have any questions